This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you who are new here, welcome. I'm a Med-Peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh. I work in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We've been coming to you since October of 2016. I hope everyone had a wonderful holiday. We have been a little MIA, which I apologize for. It's been busy. We've been busy. And I'm doing my best to get these episodes out. I think we have a great one today. As a quick reminder, if you're listening, courtesy of the University of Pittsburgh, so thank you, University of Pittsburgh, we have free CME credit to anyone listening. Just click on the link at the bottom of the podcast description, answer a couple questions that I write that are pretty easy. I don't make them hard, and you can get your free CME. And for those of you who are working now in pediatric hospital medicine or in pediatrics in general, what you know is we are busy. We are still very busy, although things have gotten a little bit better in Pittsburgh in the past couple of weeks. And one of the things we have been seeing this whole pandemic is a brand new entity, which I have to tell you is the first time in my career that's ever happened, where a brand new condition just pops up and we have to adjust as we go. MIS-C, and that is Multi-Inflammatory Syndrome for children. And one of the things we're going to talk about today is how MIS-C and the heart, because really the heart is one of the organs we really worry about the most with MIS-C. We're going to have a nice discussion. I have two wonderful guests with me today, and we're going to have a round robin with different subspecialties. So first, I'm going to introduce our guests, and we're going to get into the conversation. My first guest is Dr. Margalit Rosenkranz. Dr. Rosenkranz is an assistant professor and attending physician in the Division of Rheumatology here at UPMC Children's Hospital, Pittsburgh. She's been so for the past 17 years, and she has been involved in the treatment of MIS-C patients since the first cases started to appear in Pittsburgh back in 2020, and works on our Children's Hospital of Pittsburgh committee to formulate protocols for the treatment of MIS-C, and she has been involved in national MIS-C research projects. Our second guest is Dr. Tyler Harris. Dr. Harris graduated from the University of Virginia School of Medicine prior to completing his pediatric residency and pediatric cardiology fellowship at Lurie Children's Hospital and Northwestern University in Chicago. Here in Pittsburgh, he directs the inpatient cardiology consultation service and leads the cardiology department's Kawasaki's disease and MIS-C clinic. He's an expert in the clinical care of hospitalized children with cardiac disease and follows the majority of MIS-C patients in Western Pennsylvania as an outpatient. In addition, he studies Kawasaki's disease and MIS-C outcomes along with researchers around the globe. So Drs. Rosenkranz and Harris, thank you very much for joining us today.
Thank you for having us.
Thanks for having us, Tony. Appreciate it.
All right, so let's get into this. So I think, before we get started, we're going to have to do, because there's a CME podcast, our conflict of interest statements. I will go first, our disclosures, and then I'll kick it out to you, Margalit, and then you, Tyler, in that order. I have nothing to disclose.
And I have nothing to disclose.
And I also have nothing to disclose.
All right. So let's start with the definition so we're all on the same page talking about the same thing for MIS-C, if that's all right. As per the CDC, the definition I have is MIS-C is an individual less than 21 years old presenting with fever, laboratory evidence of inflammation, and evidence of clinically severe illness requiring hospitalization with multi-systems, which is more than two organ involvement, and that can be cardiac, renal, respiratory, hematologic, GI, derm, and neurological. And there's no plausible alternative diagnosis. And they have to be positive for current or recent SARS-CoV-2 infection by reverse transcriptase PCR, serology, or antigen test, or COVID-19 exposure within the 4 weeks prior to the onset of symptoms. They got to have fever for more than 38 degrees Celsius for more than 24 hours or reporting subjective fever lasting more than 24 hours. And then included but not limited to one of the following elevated inflammatory markers: elevated CRP, ESR, fibrinogen, procalcitonin, D-dimer, ferritin, lactic acid, LDH, or interleukin-6, elevated neutrophils, reduced lymphocytes, and low albumin. So Margalit, I'm going to start with you. Is that a fair definition? Is that what you use?
Yes, this is a definition that we use in general to try to see if a patient has the clinical symptoms and the lab findings, exam that will fit for MIS-C. And as we're going to talk about a little bit later, it can be a little bit confusing because this can look like a lot of different things. But yes, we do want the patient to fit this definition.
Perfect. So now we're talking about epidemiology, or how much MIS-C is out there. There's two major articles, for those of you keeping track, I looked at to look at this. The first one is by Payne and Galani et al., which is Incidence of Multi-System Inflammatory Syndrome in Children Among U.S. Persons Infected with SARS-CoV-2. It was in the JAMA Open Network in 2021. I didn't use that one as much, although that was a pretty good one. They had 7 U.S. states. It's from August to December 2020. They had New Jersey, New York, Michigan, Maine, Georgia, Connecticut, and Pennsylvania. The reason is it was so far back, things have changed so much. There's another article I liked a lot from the American College of Cardiology Expert Analysis from November 2nd, 2021. The authors are Michael Philip Fandora and Matthew Oster. The article is 10 Things to Know About MIS-C. And the incidence they quote is incidence of MIS-C is 316 per 1 million SARS-CoV-2 infections in those less than 21 years of age, which works out to about 1 per 3,000. The median age is 9 years old. 75% of cases have no prior comorbidities, which was a bit of a surprise to me. And the highest incidences are in Black and Hispanic Latino children, with the incidence in Black children not explained by COVID-19 rates, which is some of that inequity we had been talking about. I'll start with you, Margalit, and I'll ask you, Tyler, to join in. Does this sound right?
Yes, it does sound right. This isn't a common entity that we're seeing, but we're certainly seeing lots of kids in our hospital with it, because by definition, these children who have MIS-C, they are children who need to be hospitalized. So yes, I looked at this article as well, which I feel did give a nice summary about the incidence of MIS-C.
Yeah, I think it's tough to know exact numbers because of issues with reporting and knowing how many COVID infections there are. So your N is a little bit tough. But I think there's been multiple people who've tried to report this incidence, and I've seen something between 1 in 3,000 to 1 in 7,000, which ballpark is a reasonable number, in that it's something you're going to see if you see lots of kids, but it's not something that every single parent should be expecting when their kid gets COVID, which I certainly deal with my own kids and friends of friends, and it's still mostly unlikely that your kid will have MIS-C if they get COVID, but it's also not lightning strike levels of unrare.
Yeah, and I've seen this a lot more where parents are worried about it. And to break the numbers down again, it's for every 3,000 kids who have COVID, one of them will get MIS-C. So you're already dealing with a smaller group. And it does put us in an interesting position, and you're right about this, Margalit, because of all the kids who get COVID, we only see the sickest of the sick at a children's hospital. And all the MIS-C kids, for us, all of Western Pennsylvania's MIS-C kids come to our hospital. And so we're going to see all of them. So the incidence to me, when I first read it, I was like, oh, that's kind of low. I thought it'd be higher than that. We're seeing all of them. So we're a little bit skewed.
Yes, absolutely.
All right. So now that we've gotten that out of the way, let's talk a little bit about, do we know the prevalence of MIS-C strain versus strain? So alpha strain versus delta strain of COVID-2 versus Omicron now. And I'll start with you, Margalit, again. Do we have any idea how Omicron is bearing up or how the others did?
So right now with Omicron, we're really not sure because the surge has just happened, and we generally see MIS-C about 4 to 6 weeks after these surges. So we're thinking if we do see it, it will be more in February, March. In regards to the others, we certainly saw with Alpha, last winter, we had a huge number of children for us again, with MIS-C admitted. And that was really from October to March or so, where we had lots of kids admitted at one time. We were expecting the same thing with the Delta variant, this past fall, but it actually didn't really happen. So we did have some kids, but it certainly didn't seem that variant was causing as much MIS-C as as alpha.
I completely agree. The CDC has a nice tracker of this. If you go to their COVID data tracker, there's an entire page on MIS-C tracking, because this is still a reportable disease. So in the same way that hospitals are required to report certain infections, they're required to report MIS-C cases to the state. So here in Pennsylvania, we report to the state of Pennsylvania. So we have a decent number on that data. And so the CDC publishes this, and we saw up to about 35 cases a day around the country of MIS-C back last winter, about a year ago. And then that peak was only 15 to 20 cases this fall with Delta. And like Margalit said, is we don't really know yet, because the lag of this illness is 4 to 6 weeks behind the surge of Omicron. Plus, then you have to take the time to have somebody input all the data into the website and release that. So it lags a little bit. I will say I was expecting the end of January, early February to be getting lots of phone calls from my colleagues. I have not gotten those as much yet. It's kind of been a steady drip, which I'm hoping it stays at a steady drip, but we'll see more. Hopefully vaccination is affecting that. And that's some of the thought behind why Delta was not as high as Alpha, is because there was a group of patients, certainly the older than 12 population was vaccinated in that group. We certainly in August, September didn't have the less than 12 vaccinated just yet, but perhaps that's part of it. And so hopefully, as we've continued to vaccinate more kids, and hopefully work our way down under 5 here soon, that'll continue to blunt that peak.
That's an interesting point, Tyler. So do we know, or are we hoping and kind of assuming based on an educated guess that the vaccination should decrease MIS-C, meaning if you're a patient who would have gotten MIS-C had you gotten COVID and you got vaccinated beforehand, you would not get MIS-C?
So I really hoped that, and I thought on an educated guess it would be great. And so I was very forward as a cardiologist who sees a lot of MIS-C with friends and family and patients that they should get vaccinated. But luckily, in the last month, we actually have data. So 2 weeks ago in MMWR, a study run by the CDC looked at MIS-C incidents from July of 2021 through December, so the second half of last year, and saw that MIS-C rates were almost exclusively in unvaccinated kids. They estimated that vaccination reduces MIS-C by 95%, and not a single kid who went to a pediatric intensive care unit was vaccinated. So the few kids who got MIS-C who were vaccinated didn't end up in the ICU, didn't end up on iotrops, didn't end up very, very sick. They were just medium hospital sick, which is a significant improvement versus every kid that went to an ICU, every kid that needed significant inotropic or mechanical circulatory support was unvaccinated. There's a similar study in France that has corroborated that data I saw from the last 3 to 4 weeks, and I don't have that reference off the top of my head, but I saw that as well. So I've seen at least now 2 studies that suggest vaccine does in fact decrease your likelihood of MIS-C, which, as a person who sees a lot of MIS-C, was about the best news I got in the month of January.
Yes. Yeah. And also, just to add to that, we have this listserv for pediatric rheumatologists, and people are reporting when they're seeing MIS-C. One of the things to go along with that is the few reports that we're having that suggest it's from the Omicron variant, they are younger children who are getting MIS-C. So the possibility that has to do with the older kids being vaccinated as well, and not that Omicron is causing MIS-C more in younger kids, may also go along with that data.
There have been case reports of breakthrough MIS-C through a vaccine. I have seen one case report of MIS-C due to the vaccine, or at least that was a case report. Whether correlation and causality is true or not, but those are case reportable type pieces of data. So it certainly seems to be reassuring.
Yeah, I mean, I remember when we first started seeing MIS-C last year, everybody was in the ICU and everybody was quite sick, and it's gotten better. And I love that the vaccine has a role with that. I really do. Yeah. But one of the things since the beginning of MIS-C being discovered is it's been linked to Kawasaki's, or initially was treated, it was thought to be more Kawasaki's. And there are some similarities, but one of the things that we said in the definition that really stood out to me was in the epidemiology, was the idea that the most kids who get it, 75% of kids who have MIS-C have no prior comorbidities. And that actually, to me, it made me think of Kawasaki's, because we don't, and I'm going to ask you this, and with Kawasaki's, there's no known comorbidities to bring it on. We don't know why some kids get it. And MIS-C seems to be along that vein in that specific sense. Am I right?
Yes, absolutely. And really the majority of kids we saw were healthy, athletic kids who were admitted. A few of the kids may have had a comorbidity. I think the most common one we saw was obesity, but it was a minority of these patients. So yes, very similar to Kawasaki, that these are, kids who have that COVID causes some sort of immune dysregulation in an otherwise healthy child. Now,
the other sense where we've thought about it with Kawasaki's, and I think I had a patient, and I thought about this at length. When you have Kawasaki's, if you don't treat Kawasaki's, your fever and clinical symptoms will eventually get better. They'll abate on their own. It's self-limit. But the concern is, of course, coronary artery aneurysms down the road, which when you look at the guidelines, if you do not treat Kawasaki's, about 25% of patients could get aneurysms. Now, MIS-C here is different, because if you don't treat it, it will just continue to worsen until serious illness or death occur, which is very different. And am I right about that? We'll start with you, Margalit, kick out to Tyler.
Absolutely. With kids with Kawasaki, sometimes we debate how long have they had fever? What are their symptoms? Does it really fit Kawasaki? Kids with MIS-C, you really can't wait. These kids, within a few days of having fevers, tend to get very sick. And the cardiac dysfunction is more myocarditis and some, ventricular dysfunction, as opposed to the longer term coronary arteritis that you see in Kawasaki. So absolutely, these kids are not kids who you're seeing hanging out with a fever for, quite some time with no other symptoms. They're very sick and they're coming to the ICU or, seeking care in the emergency department.
Yeah, I think that's exactly right. I think these kids get much sicker. Their inflammation seems to be more profound and affect them in ways that are different than Kawasaki's. The way I kind of explain this to families, because we don't have a lot else that looks like this. This is a distant cousin of Kawasaki's, but it's a much older, much meaner cousin of Kawasaki's, in that some of the features are the same. And I will tell you, there have probably been kids in the last year and a half to 2 years who've had what would have met a textbook definition of Kawasaki's in 2015 that in 2021 probably get called MIS-C, because it's tough to differentiate the two sometimes. They might have all of the clinical features of KD and might look for all the world like KD, but they also have a COVID positive history. And so we treat them like a little bit of both. There's some interesting research looking at this, and the immunologic cascade of MIS-C looks like some sort of hybrid version of Kawasaki's with toxic shock syndrome. If the two got together and hung out, that it's somewhere in between the two, in that it's some sort of profound immunologic reaction that's a little bit like Kawasaki's, both clinically and on lab testing, and is a little bit like toxic shock syndrome, and certainly their profound vasoplegia and shock and dysfunction that we see kind of realms like that. And so it's an overlap of these two things. So they're related. They're sometimes hard to distinguish. And the only thing I know as a cardiologist who treats patients with KD with a lot of data back in March of 2020 was IVIG and aspirin makes kids safer with Kawasaki's disease. So I didn't want to withhold that treatment that I know is effective in case it was a different entity. And what we figured out is they're related, but not the same entity. And I treat them a little bit differently, but knowing that I'm not always perfect at differentiating the two. And there's emerging data to try and help us be a little bit more accurate in defining the difference between acute COVID, Kawasaki's disease, complete KD, incomplete KD, or something completely different. And there's lots of interesting case reports coming out now that we've gotten good at identifying MIS-C, is we thought this was MIS-C and oops, we were wrong. What else is it? And there's tons of interesting case reports of we thought this was MIS-C and oops, we were wrong. It was X, Y, or Z. And there's lots of those now.
If there's two diseases I wouldn't want to get married, it's toxic shock syndrome and Kawasaki's disease.
Yeah.
I would prefer they had not hung out as much, but oddly, they were similar.
Margalit, I think I interrupted you. Were you going to say something?
No, I actually agree with everything that Tyler said. And some of these kids really do come in looking like Kawasaki, but then there's a group of kids who come in more that shock, and they don't have the features of Kawasaki. They have more diarrhea, abdominal pain, vomiting, headaches, neck pain, but they have some blood pressure instability. Sometimes if you have a child, that you think may have symptoms of it, may have the clinical characteristics of Kawasaki. I mean, you think it might be MIS-C. Sometimes it makes it a little bit easier to diagnose right now since we're seeing this pattern. But the kids who come in with all of the other organ dysfunction it can sometimes be very tricky to differentiate the different conditions. And as Tyler said, we're not always right, but we do want to make sure this is something that we don't miss.
Along those lines, Margalit, we were going to talk about this later, but this is a perfect segue into it. Diagnosing this, like we're saying, is hard. The kids that come in with clear shock and had a history of COVID 4 weeks ago, and their inflammatory markers are all high and they're in the ICU, I think those are a bit easier because you're just going to treat them to get them better. But for the kids that come in, especially the Pediatric Hospital Medicine Service, and we're back and forth and thinking, could this be or could this not be? Are there specific lab values that help you? Is it all the history and physical? Do you just err on the side of caution and work it out as you go? What, as the subspecialist we call, how do you go about this?
So I really try to take that full holistic approach. I go back to the history. How long has this been going on? For the kids who are in the ICU, it's a little bit different, but for the kids who you see on the floor, they might not look that sick. So I'm going to go back. I'm going to find out how long has this been going on? What are the symptoms? What other symptoms could they have? Could this be a pneumonia? Could this be a urinary tract infection? Try to think about all of the different symptoms. And then in terms of lab findings, interestingly, there are some that can really help to differentiate to, Kawasaki. Of course, these kids have very high inflammatory markers. Interesting, their platelets are low. Kids with Kawasaki, they come in often with normal or high platelets, but these kids come in with platelets on the lower side, not bottomed out, but in the hundreds. And with inflammation, you would expect platelets to be, more elevated. The other thing is the lymphocyte count is, I would say, almost uniformly low in these patients as well, which is, just also very interesting. Other lab tests, we send Tyler can address this more with the troponin and BNP, but I don't think that those are the most significant in terms of differentiating. So we really do try to focus on that. Right now, too, with COVID being so prevalent, the COVID antibodies, they should be helpful, but we knew this was coming where COVID antibodies weren't going to be the most helpful test, because it doesn't tell you when they were exposed. It doesn't, give you that much information, but certainly we do like to see those COVID antibody, the spike protein, being positive.
Tyler, you want to talk about the BNP and troponin?
Yeah, I think more information is sometimes better and not always. I think what we've learned now that most kids coming into our ICU now that are really sick get BNPs and troponin sent. And while patients with MIS-C are more likely to have inflammation and dysfunction of their heart muscle, thus leaking troponin and having BNP stick around, that's not the only thing that can do it. And there's tons of data that's showing it's not very... And it turns out bacterial sepsis can do it, and pneumonia can do it, and lots of other things that can make you really darn sick. And I have said this to a lot of my PICU colleagues is that if you randomly started looking at BNPs and troponins around the PICU, you're going to find a lot that are just a little bit abnormal, because they're sick patients whose bodies are sick and their heart can be more stressed by that. And so it's a non-specific marker of stress in the microbiome. Now, very high BNPs, very high troponins, There are not as many things that do that. And so it can be a little bit more specific, but I won't live with just a BNP troponin as a reason. And it's more of the complete holistic history. And Margalit made a good point. And I've unfortunately seen enough of these kids now that you start to get into a rhythm, and you start to know when things sound and walk and talk like a duck, and you sometimes note when it might be a goose or a bear. And so the history is not quite right. Your COVID exposure was 6 months ago. You're a little bit inflamed and a little bit febrile for a day, but don't have a lot of these. I think the other things that have been clinically more obvious is it's the abdominal pain that is the unique and vomiting and diarrhea that is the unique feature of MIS-C as opposed to a lot of other hyperinflammatory syndromes. I know a number of kids who've had their appendix taken out and ended up diagnosed as MIS-C with a normal appendix because they have profound abdominal pain and diarrhea and vomiting, and even CTs with evidence of ileitis and colitis. I saw a CT in one of our patients read as acute Crohn's disease.
Oh, sure.
Was the read from radiology when we didn't know what it was. And 2 weeks later with a repeat CT had a completely normal abdominal CT after anti-inflammatories because the GI inflammation is so profound. So those are the things that tend to clue me in. But yeah, it's profound inflammation. I think the other thing on the complete other end of this is you mentioned this in the beginning, and the definition of this illness is these are severely sick kids. So I get a lot of phone calls of, do you think this kid could have MIS-C? And he's a kid who's had a fever for a day and a half, and he's running around the house and eating cheeseburgers. And could that kid develop MIS-C? Sure. But the definition of this illness is a really sick kid in the hospital. And so if you're not a really sick kid in the hospital, you probably don't have MIS-C yet. And so, and then the other part of the definition that it has become more important is no other plausible alternative diagnosis. So we have lots of kids where at first we say, yeah, there's no plausible alternative diagnosis. This might be MIS-C, and then their blood culture grows them. And then they all of a sudden have a plausible alternative diagnosis, and they no longer meet the definition. Because really, if you look at the definition of MIS-C, it's not all that different from bacterial sepsis, except for you don't have a positive blood culture, and you recently and you live in an era where you probably could have picked up COVID, and we don't have lots of kids with bacterial sepsis all the time. But it turns out bacterial sepsis has all of those markers of inflammation and being really sick and in shock. And so it's tough to differentiate. And sometimes it takes blood cultures, 12, 24 hours to grow.
Yeah, along these... Oh, sorry, Margalit, I didn't mean to interrupt you.
Oh, no, one other thing I just wanted to add too, I've had pediatricians who their patients have been diagnosed with MIS-C, and they've asked me, did I miss it? Is this something that I missed in the office because this child came in with abdominal pain, some vomiting and diarrhea? I say absolutely not, because you saw them at their illness that was at that point maybe 2 days. This is something that will progress rather quickly. So at some point they may get much sicker, and the pediatricians can always give some guidance in terms of when they should go to the hospital. But I just did want to mention too that this can look like anything, and not every child with abdominal pain and diarrhea and fever is going to be admitted to the hospital.
Yeah, absolutely. Most of them are going to be gastroenteritis.
Yeah, exactly.
We are seeing quite a bit of gastroenteritis, so that's very fair.
Yeah.
Now, let's talk about the heart a little here, Tyler. I want to talk now for Kawasaki's. We worry about aneurysm as the worst possible cardiac abnormality that Kawasaki's can cause. Is MIS-C the same? Is aneurysm what we're most worried about with MIS-C pertaining to the heart?
Yes and no. It's similar, but slightly different. So Kawasaki's it does have a pancarditis in that it can affect every layer of the heart: the endocardium, the myocardium, the epicardium, and importantly, the medium-sized vasculature, which is the coronary artery. So Kawasaki's disease. Typically, we think about coronary artery aneurysms, but Kawasaki's disease can have left ventricular dysfunction. It can have mitral and aortic regurgitation. It can have pleural effusions. Well-known Kawasaki's complications, though more typically coronary artery aneurysms. MIS-C, on the other hand, much more likely to have myocardial dysfunction. It seems to be more trophic to the myocardium than to the vasculature. And so myocardial dysfunction, heart not squeeze very good, typically left ventricular, but sometimes right ventricular dysfunction, is very common in MIS-C. Up to 50 to 60%, depending on where you catch them in their illness, will have some level of dysfunction of the myocardium. And then the incidence of coronary disease is lower. It's more in the range of 5 to 10% if you look at the data, and the aneurysms are significantly smaller than in Kawasaki's disease. We've had very few patients, both locally and nationally, with the large and giant aneurysms, which is what we really care about with Kawasaki's disease. Lots of kids with Kawasaki's disease will have small aneurysms. Turns out those kids do fairly well and have a fairly limited increased risk of coronary artery disease in the long term compared to the general population. It's the medium and large and certainly the giant aneurysms that I worry the most about in Kawasaki's. And we seem to have a lot less of those with MIS-C. So we see dysfunction, we see coronary artery changes, we do see effusions, we do see mitral regurgitation with fairly commonly, although it almost universally resolves the second they see an anti-inflammatory medication. And then we do see some rhythm disturbances. About 5 to 10% of patients have some rhythm issues, whether it be transient first-degree AV block or ventricular arrhythmias, primarily PVCs, and occasional PACs, although those almost universally have resolved. I have one patient who continues to have PVCs, although I think they probably had them before their MIS-C, and we just picked it up.
So then, since you brought that up, along those lines, you're seeing these kids, almost all of them in Western Pennsylvania, as an outpatient. Do these cardiac disturbances you're talking about, the dysfunction, the aneurysm, the rhythm disturbances, the effusion, do they all resolve?
Yeah, both locally in my own experience and then based on national data is the overwhelming majority of these kids, all of these things go away. And so we now have published data up to 6 months and then local personal data up to about a year and a half. And what we've seen is almost all of these kids, whatever coronary aneurysms they had resolve within the first couple of weeks. Whatever myocardial dysfunction typically gets better before they leave the hospital, quite honestly. And if it doesn't, it's typically normal by the time about 4 to 6 weeks out. We have one patient that I know of here who has significant residual coronary anomalies, and it was from someone who was much earlier in the pandemic when we weren't sure what this entity was, and so was inflamed for longer. And that's what I've seen is the longer kids are inflamed, the more significant things I see in the myocardium, and the longer it takes it to get better, versus the kids who were picked up earlier and were not as sick. They're typically normal by the time they leave the building, versus the kids who have prolonged courses, needed more anti-inflammatory medications, take a little bit longer. But both locally and nationally, this seems to have recovered. Do I have 10-year data on this? Absolutely not. And I have 10-year data on Kawasaki's, which is why we keep comparing this to Kawasaki's, because it helps me to talk to families about long-term prognosis, because I have great long-term data in Kawasaki's, and I can tell you exactly what your risk factors are based on the level of your coronary artery disease. But right now, I can't tell families there's no chance you're going to have long-term cardiac comorbidities. But a year and a half, 2 years out of following this, what we've seen is that most patients recover very quickly and very few patients have long-term dysfunction, long-term coronary issues. And I think, and I do not know, that will continue into the long term as they become young adults and old men like me.
Let's round this out then. So for the athletes we're seeing, and Margalit brought this up earlier, that in the beginning especially we saw a lot of young athletes. What's the purpose from the cardiology perspective of the echo and then the clearance of these MIS-C kids before they go back to sports? What are you most worried about?
Yeah, so from an imaging perspective, I want to see that their coronary arteries look normal, and I want to see that their heart function has normalized. It tells me that their myocardium is recovering. And it's a non-specific way to tell me that my myocardium is recovering, but it's been pretty good. As far as exercise restriction, this is tough. I hate exercise restricting kids. I was an athlete myself, and if someone had told me you can't go to swim practice, I'd have been pretty ticked off at them. So I don't like doing it. But where this comes from is historically kids with myocarditis, which is a non-specific diagnosis that says your heart muscle is inflamed. And there's hundreds of different reasons it could be inflamed. But in the 80s, 90s, early 2000s, in order to know your heart muscle was inflamed, it's typically because you came in shock with abnormal echoes and abnormal physical exam. And patients who had significant inflammation of their myocardium then for a period of typically 3 to 6 months are at higher risk of having a ventricular arrhythmia, which leads to sudden cardiac death. So if you look at historical data on the causes of sudden cardiac death with exercise in children, and young athletes, even up to college-age athletes, myocarditis is the number 3 cause of sudden cardiac death with exercise. Most common is going to be hypertrophic cardiomyopathy. Coronary anomalies are going to be the second, congenital coronary anomalies, but the number 3 cause is resolved myocarditis that then leads to a ventricular arrhythmia and leads to sudden death during peak exertion. That's not good, and we try to prevent that. So the way I explain this to families is if you go out and sprain your ankle and you have inflammation on your ankle, I put a boot on it, I put a brace on it, and I tell you to put it up on ice for 2 to 6 weeks and go easy. And then when you come back to playing basketball, take it easy and wear a brace. And slowly rehab your ankle inflammation. And I think of the heart as the same way. It's just hard to put a brace on you. And so I think about exercise restriction as a brace for the myocardium in the period that I know it's inflamed and susceptible to having abnormal rhythms. And the thing that makes it susceptible to having abnormal rhythms is higher endogenous epinephrine and asking it to do more, asking your heart rate to be 160 for an hour as you play a basketball game or go to swim practice, and stress that inflamed muscle. And so that inflamed muscle then doesn't turn around and give you ventricular arrhythmias. So that's the concern with myocarditis in general. Any cause of myocarditis in general is that heart muscle might be inflamed, and that inflamed muscle then might turn around and give you an arrhythmia. Do I know that happens with MIS-C? Nope. Don't know any data that says that. Have not seen any case reports of sudden cardiac death with exercise after MIS-C. Got no data to support that. But I know their heart muscle's inflamed. I know it's really inflamed for a short period of time. And what I don't know is when that heart muscle is no longer inflamed and when that heart muscle is completely safe to go back to full strain. There are some data from our MRI studies that have shown that any inflammation we see on a cardiac MRI in MIS-C resolves in 6 to 12 weeks. With not a lot of long-term scarring that we see in other causes of myocarditis. So typical pre-2020 myocarditis were typically caused by viruses, enteroviruses and Kawasaki viruses and things like that. And that causes scarring of the myocardium because it's a direct virus infiltrating the muscle and it kills muscle. And that muscle then becomes electrically active. And so we can see that on MRI in those patients. We don't see that on MRI in these patients. I've sent some patients to the exercise lab to run on a treadmill to prove to me they're not going to have abnormal heart rhythms when they run. And those have looked normal, both in my patients and other places. And so based on the data I've seen, based on my experience with other causes of myocarditis, based on the fact that we have a treatment for this that makes the inflammation go away, I feel pretty comfortable saying that for a short period of time, you got to put your heart up on ice and rest it and watch some Netflix. But at some point, you should get back to your normal activities because that's important to you and also important for your cardiovascular health long term. And so do I know exactly when that point is yet? No. We need more good long-term data to give us better timing. But a period of restriction that is somewhere between 4 weeks and 6 months, depending on the patient, is reasonable and stuff we do with other patients, if that makes sense.
That makes a lot of sense. And Margalit, I want to bring you into this because we keep talking about the inflammation, and the treatment for MIS-C around the country seems to be IVIG with aspirin and steroids with a prolonged steroid taper. Am I correct about that?
Yes. So as you mentioned when we started this conversation, this is all new to us. Well, I mean, we've seen similar things, but this in general is new to us. So when we first started getting reports from the UK and Italy back in February and March of 2020 that this entity existed, and then it hit New York City. So we talked to all of our friends there. What are you doing? And everyone was doing something different at that point. Some people were doing steroids. Some people were doing Actemra. Some people were doing IVIG. There wasn't a huge consensus as to what to do, how high steroid doses. So in the beginning, we were trying different things, but for the most part, what we've been using are IV steroids and IVIG pretty much universally in these patients. And what we've noticed over time, as we've been learning, is that treating with doses that are a little bit higher for steroids, especially if the child is a little bit on the sicker side or need in the ICU needing pressors, we're going to go to the higher doses of steroids. Somebody who might be on the floor, who might not be as sick, we might do a medium dose of steroids. But we've noticed that giving the higher doses of steroids early seems to make this turnaround time of them turning around. Sometimes you see them, they come in, they're in the ICU at night, and you see them the next morning and they're sitting up and they're talking and they look much better, even if their labs haven't, reflected that. So the two main ones are the steroids, the IVIG, and then because this is similar to Kawasaki and the heart involvement, the aspirin. Sometimes we need to go to other medications as well. Some other immunomodulatory treatments. There's a medication called anakinra. When do we know? How do we know when to use it? So these are kids who are in the ICU. They're still on their pressors or on epinephrine. They're on norepinephrine, and we're not able to get them down. They still have fever. So we will add something like anakinra. Again, this is very institution dependent. Our institution is very comfortable using anakinra. Other of my colleagues in other places in the U.S. Have used Remicade, and other places are using Actemra. So I don't think there's any specific consensus. I can say that it's very rare that we have a patient where we can't get them stable within a couple of days, where they're out of the ICU and on the floor. So I think our treatment right now, is reasonable, and it seems to have a good effect. A very few number of kids also in the beginning, we tapered off their steroids a little bit faster when they, went from the ICU to the floor. Ended up going back to the ICU because, they just weren't able to tolerate the wean. So, and one of the main things that helps to guide us in terms of, okay, when can this child looks better? When can we change them? As you mentioned, we send them home on a longer term steroid wean. When can we change them to oral steroids? What seems to be the biggest determinant is not really their lab tests. Most of these kids they're not febrile anymore. It's their abdominal distension. And if they're not able to take an oral steroid and absorb it, we're not going to be able to send them home on that. So that seems to be what helps to guide our therapy in the hospital. Once this child has less abdominal symptoms, they're able to eat, they're able to take oral steroids, we're able to then really switch them over. And as you mentioned, we send them home on a long, for rheumatology, it's not really a long steroid taper. It's 2 to 3 weeks.
Okay.
But it's for any family who has a child who's on steroids, it's a decent amount of time to be on steroids. And we have we've seen well over, I don't know, maybe 100 kids with MIS-C at this point. There's only been one child who had to come back because her fever came back. And again, I think this was early on, and I think her stomach issues were the big issue at that time, and she wasn't absorbing the steroids. And she really was back in for maybe a day or two until we got her feeling better.
Now, can I follow up with that, Margalit?
Yeah.
So do you all, I'm assuming, then start with the steroids and IVIG, mm-hmm. and if the patient then doesn't respond, you would consider adding one of the immunomodulators you discussed. Yes. Is that right?
Absolutely.
Okay. And those cases of that resistant MIS-C, which is lack of a better term, mm-hmm. that's what we'll call it. Those are rare.
They're very rare. And I really think in the beginning, I think we were using a little bit more anakinra, but I don't think our steroid doses were as high. I don't think we were treating as aggressively. So we still do occasionally use anakinra, but it's short term. The kids are not going home on a medication like anakinra. We're stopping that in the hospital. The only things they're really going home on are the oral steroids, and the aspirin.
And Tyler, can I bring you in on this? When you're seeing these resistant cases of MIS-C and our rheumatology colleagues have added immunomodulator, are you expecting more cardiac issues?
Yeah, I typically, I don't have a lot of data on this yet. I'd like to look at our data and look at other groups of data. My kind of gestalt from taking care of these kids is the longer they've been inflamed when they get here, the longer it takes to turn them around on the back end, and the more medicine it takes, and the worse their cardiac dysfunction is. And it's a little bit close to what I've seen at, but yeah, the kids who take an extra medication who are still inflamed after steroids and IVIG, their cardiac inflammation typically hasn't turned around yet, and they typically have longer durations to normalization of their dysfunction. The coronary side, the coronary complications have not been as linear in that way. They tend to be a little bit more random. But yeah, I do expect that if their fever's not gone and their inflammation is not downtrending, that I'm not all that expecting their echo to be better yet. And that typically once they start trending down, then all of a sudden their echo will turn around very quickly. But there have been a couple kids who just need a little bit more time on IV steroids, or a little bit more steroid, or maybe need a second medication to kind of stamp things down, and that takes them a little bit longer. And I think that's when they start accruing non-cardiac comorbidities that I think end up being the long-term guide of how much effect these kids have. So I would tell you most of these kids' hearts get better, but if they accrue a additional comorbidity while they're in the hospital, these kids are in an ICU and very sick. And do they get a DVT or a blood clot somewhere? Do they get a secondary bacterial infection? Do they get, we've had a couple kids with steroid side effects, whether that be adrenal or due to hypertension, significant hypertension. We've had a couple kids who have had seizures due to PRES, posterior reversible encephalopathy syndrome. So complications like that. And the national data has shown that the deaths and the significant comorbidities in these patients, which are rare, less than 1% of MIS-C kids pass away, but it's almost always due to another organ system complication, typically neurologic, so a stroke or brain injury, although renal injury and liver injury have also been seen, and they tend to guide the long-term recovery is how much inflammation did you have that really knocked off other organs, whereas most of the time their heart will come back around.
And Margalit, we've talked how new this is and how helpful the steroids have been. Do we have a mechanism of action for how it's working yet?
How MIS-C is
How's the
working,
steroids help?
How are the steroids helping? The steroids act like a fire extinguisher for inflammation in general. And so we know this is a very hyper-inflammatory state. We also call this a hyperferritin state because most of these kids, their ferritins are very high. And we know that steroids in general work very well for these acute syndromes. If MIS-C were to be, something that were more of a chronic issue, then we would have to talk about longer term immunomodulation. But because what we're treating is inflammation, steroids work really, really well. The IVIG, again, this is more because of Kawasaki data and because of the heart. And that's why we're giving IVIG as well, but it certainly has immunomodulatory effects in general in the immune system. We don't really know why IVIG works well in a lot of other conditions, but there are a lot of different theories behind it, but it works. And so the combination of the two seem to be excellent for MIS-C. And I certainly have to give a lot of credit as well to our ICU. Our ICU at Children's Hospital is phenomenal, and they pick this up and they treat appropriately very quickly. It may be one of the reasons too why the kids that we see have done so well.
I have no doubt that's the case.
Yeah.
Rapid identification and rapid initiation of therapy is the reason our kids have done well, I think, and why I think looking at our patients, our complication rates are lower than what you see reported in the literature. I think our team as a whole hospital is really good about picking up these kids and getting on top of them and supporting these kids because, you need a lot of these kids need support until their organs can recover, and they need nutritional support, and they often need pressors and fluids, and those are tough things to do. And I think luckily, both in our hospitalist floor in our ICU, people are on top of this really well and why it allows them to recover.
Absolutely.
Yeah, I will agree. I tried to get our ICU in on the show, and unfortunately, those who could do it were super busy and were unable to join. But lots of appreciation and thanks and appropriate credit to the ICU because they managed the bulk of this, especially early on, and they would send us patients that were pretty well tied up between cardiology, rheumatology, and the ICU, and we got them afterwards.
Yeah.
But let's round out. I've kind of gone through most things I wanted to talk about, but Tyler, I was hoping there has been a lot of misinformation about myocarditis and the vaccine versus actually getting COVID. And as part of our duty and our responsibility, I was hoping you could really shed some light on this so we're all on the same and right page here.
I would absolutely love to do that. I do this every day in clinic. There are probably three different entities we should talk about. So as far as just the heart, let's not talk about any other organ. Let's not talk about public health and passing it to family members and the problems with missing school and work for families. Just the heart. That's the only thing we want to talk about. Why does the vaccine make some sense? So the COVID itself, very well known to cause inflammation of the heart. So you can get inflammation, myocarditis and inflammation of the heart just from an acute COVID infection. In fact, that's what started all of this craze back at the beginning, is that hospitalized 50-year-olds in Germany initially reported had profound myocardial inflammation when they were on a ventilator for COVID. And so that's what then, if you remember back, they held up all the sports and the Big Ten didn't want to play football because they were worried about inflammation of the myocardium due to COVID. We've now studied that, and we know that incidence is low, but not zero. So we know that kids who get COVID can have some level of cardiac inflammation. It tends to be moderated fairly closely by how bad their COVID was. So if they didn't have to go to a hospital and they had a fever for a day and a half and some sniffles, they probably don't have that much cardiac inflammation. But if they needed to come to a hospital for their COVID and needed breathing help, they probably have more cardiac inflammation. So that's one way you can get inflammation in your heart, is by getting COVID. Two, you can get inflammation in your heart from MIS-C. And we've, I think, now documented that MIS-C is bad, that you have to spend time with intensivists, which is never good, and that there are lots of complications, and that you need lots of medicines that I'd prefer not to give to kids. Can we do it? Yes, but I prefer not to. So you can get inflammation in your heart from MIS-C. And then the third way you can get inflammation is from this vaccine. We have seen that the vaccine causes, very infrequently, on the order of one in about, I'll list recently, 50,000, one in 100,000, typically teenage boys after their second dose can get inflammation of the myocardium, and typically their pericardium much more than the myocardium. So they present with pericarditis type symptoms due to the vaccination itself. It turns out myocarditis and pericarditis secondary to vaccination is older than I am. Was seen with the smallpox vaccine in the 1940s and 50s. In the military smallpox vaccine has been reported with every vaccine we've ever developed. But because there was a lot of attention to this, we see it. I know of 6 patients at Children's since the vaccine's been rolled out for kids. And nationally, the data is, like I said, 1, and I'd have to pull the most recent data, but infrequently causes inflammation from the vaccine itself. The best thing about that, though, is that the patients I've seen is that the vaccine, the myopericarditis, or I like to call it perimyocarditis because it's more a pericarditis type clinical picture, typically gets better with 1 or 2 doses of ibuprofen and resolves very quickly, and the long-term effects have been minimal. There's been multiple studies that have now come out of Israel as well as the United States that have shown that the cardiac complications of this perimyocarditis is mild. It gets better very quickly, and there have not been significant complications in kids. So to summarize all that is you could get your heart inflammation lots of different ways. Which way would I prefer to have it? I would prefer not to have MIS-C. I would definitely prefer not to have it due to my primary COVID. And the lowest risk way to have inflammation of your myocardium is to get the vaccine. Does the vaccine cause pericarditis and myocarditis in kids? Yep, it does. Is it really uncommon? Yep. Is it less common than getting inflammation in your myocardium from getting COVID itself? Yep, you better believe it. And so this is not I don't want to get the vaccine because it causes inflammation, and by not getting the vaccine, I won't get inflammation. It's picking the way you want you're most likely to get your cardiac inflammation, right? And so the lowest risk way to have cardiac inflammation is to get the vaccine. Plus, it decreases your risk of transmitting things. It decreases your risk of long COVID. We now know it decreases your risk of MIS-C. It decreases your risk of hospitalization. It decreases your risk of getting your grandpa and grandma sick. It decreases the risk of you having to miss school and your parents having to miss work, which is not an unimportant thing as the parent of two small kids who are in daycare and school who and has a job that I like to show up for so I don't have to cancel my clinics. Are all of the reasons why I recommend this strongly to every one of our patients, including our very sick cardiac patients. And we get phone calls about this every day from our very sick heart patients, our patients with single ventricles and Fontans, our heart transplant population. We recommend this vaccine for them. And why I recommended it for my own kid. So I have one kid who has this vaccine already, and I'm anxiously awaiting the opportunity to vaccinate my other one who's too young for it. So I will put my money where my mouth is on that one. And to me, as someone who sees a lot of MIS-C, the biggest reason for me is I don't want to deal with MIS-C. And luckily, new data actually shows that wasn't just a guess, but actually has some supportive data.
Well, we've gone through all my questions. I usually do a section where I ask the guests if there is anything we didn't talk about that you would have liked to talk about or we should have talked about. And Margalit, I will, of course, let you weigh in first. Is there anything we didn't discuss that you thought we should have or we should have brought up?
No, I think that this was a really nice overview for MIS-C, and we're learning as we're going along. There's now some data coming out from our hospital that participated in this national study to help also other people in the community, other ER physicians, at places that may have never actually seen MIS-C, for algorithms and how if a child comes in, how can you diagnose? So I think we're learning more. I think we're helping to get the information out to other medical facilities as well and other medical professionals. But again, it's a learning curve for all of us.
And as an aside to that, I hope we never again have to deal with a new disease entity that rears its head just in the middle of a pandemic that we have to then figure out.
Exactly.
If we never see that again, I think we'll all be very
yes, absolutely.
Tyler, same question to you. Anything we didn't talk about that we should have?
No, I think that's a pretty good summary. I think the one thing I would say is this is not the end of knowledge of MIS-C. I think the where I counsel patients now seeing them outpatient is I don't know what it's going to do long term. We need to follow kids and figure that out. Is someone who had MIS-C 5 years ago more at risk for cardiac or non-cardiac sequelae? No idea yet. And so I don't think I would say that these kids who've recovered and are a year out are free, completely free and easy. They're always going to have that little bit of a risk factor in their past medical history, although I don't know what quantity of that risk factor is just yet, which is why I'm following these kids long-term intermittently. And I tell the families, I might not do a whole lot when you come back and make the trip down to Pittsburgh and see me, but I feel like you should come in and check in and make sure that I haven't learned something new, and why we're doing research studies and why we need funding for research and why we need the sort of research support structure so that we can take something that is not super common clinical entity with tons of factors in it and be able to say that it requires lots of patience. And so we're doing this in a lot of different ways here, both from the rheumatology group, from the infectious disease group, from the cardiology group, is in the ICU is following these patients and looking at their long-term comorbidities and looking at ways we can treat better, looking at ways we can modify our initial treatment. Maybe we don't need IVIG, which is something some people have brought up. Maybe we don't need as much steroids. Maybe a different medicine would be better. Maybe there are different ways we can identify this sooner that keeps kids out of the ICU. I would say vaccination is that way, but I'm preaching to the choir, I think. But we are continuing to figure this out, and here in Pittsburgh, we're certainly doing that, and around the world doing that with multi-institutional big data types approaches to something like this.
This has been great. Margalit and Tyler, thank you so much, both of you, for coming on the show. This has been a great conversation. I really enjoyed it.
I did too. Thank you so much, Tony.
Much appreciated, Tony. I appreciate it, and I would happy to come back anytime. It's been great. I learned a lot today, too.
I'm going to take you both up on that.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for listening.